like to introduce Dr. Adrian Trelaw, consultant in old age psychiatry, Oxleas, NHS.
Yep. Oh, didn't work. There it did. Right, but it's lovely. It's lovely to be here, and thank you very much for asking me to come. What we've done is to start thinking about what care services for people with advanced dementia look like, how they function, and so on and so forth. Now, I was learning last night at supper that the UK background is not quite the same as the Ireland background, or the ERA background. I should get it right, shouldn't I? But I think as with in both places, there's lots and lots of pressure on acute hospital care, with big overspends, big problems with unplanned emergency admissions. The vast majority of patients are over the age of 65. 90% of those in intermediate care are over the age of 75. And in fact, extraordinarily, the average age of admissions in our local acute hospital went up from something like 73 to 80 over a period of a couple of years. An extraordinary gentrification of the inpatient population, which demonstrates the pressures that we've got looking after older people. But it's absolutely true that most people with dementia go through acute hospital services, A&E and admissions in the last 6 months of life, and actually there's a strong sense that we worry about whether or not that's appropriate. Sometimes it's absolutely appropriate, and we defend and protect the rights of people to be admitted to hospital in the last 6 months of their life. But other times it's less than appropriate. Caring for people at home and avoiding the use of care homes does save money, probably saving about £17,000 per patient in the last 6 months of life. And home care of dementia until death is a rare event, poorly understood, not encouraged by statutory services. But it's a delight to come here and find that you've got 2 posters at the back describing just that, and in fact it's happening here as well as back home with us. So a quick story of Grace and Jack, just to personalise a little bit. Actually, Grace was one of the first people that I took out of a nursing home and sent home. She'd been living at home with her husband. Things began to go a little bit wrong. She began actually starting off doing what many people with dementia do, which was to have a sort of depressive illness, treated for depression, but in fact it was an organic vascular depressive illness of late onset, and she became more and more desperate. Inpatient episodes, but by the time I got there and started actually in post, it was clear that she had quite a severe dementia, and she was very agitated, very distressed, in hospital, puzzling all sorts of people. I've got to keep up with my making this animate, haven't I? And there she was, agitated, distressed, struggling, and I wondered at the time what to do with her, actually. But anyway, we treated her, sorted her out, settled her down, and she went into a nursing home, and there she just struggled. She really found it difficult. She looked agitated. If you look at a picture of her now, she looks distressed. And her husband said, I want to take her home. So we talked about that, and I said, I don't think you can. And I said, see you in a month. And he came back in a month's time, sat down with the ward sister, with the sister of the home, and said, I want to take her home. And eventually I thought, well, we're going to try this. And the worst that can happen is she might die, but on the other hand, actually, if she does well, she will do well. And in fact, Grace did do well. Her husband took her home, and she carried on living, actually, for a remarkable time, because she had a vascular dementia, and she improved and stabilised rather exceptionally. And she lived at home with her husband for about 8 years, doing well, and with really good outcome. He gradually withdrew the medicines she was on. She stopped the antipsychotics and did all those, and actually she carried on. And there's a lovely video, which I shan't show you, of her going out to Blue Water. Those of you who know South East London know that Blue Water is the place, which I don't like much, but there we are. But lots of people go there lots of the time, and it's got some nice cafes. You can have a day out. So there's a very complex thing, but there's also, somewhere in here, a very complex interplay of the different services and how you manage and support people. And gradually, hospital becomes less appropriate, and you end up potentially looked after at home. And out of that grew this thing which we called the Oxleas, or the Greenwich Advanced Dementia Service, where we believe that anyone cared for at home with advanced dementia deserved care coordination and ongoing support. And we began to learn that we put that together with a comprehensive assessment, care coordination, quick responses when things were changing, developing a palliative care framework, and certainly in a big way, developing my skills in terms of how to do palliative care, how to provide the right equipment, hospital beds, hoists, and all sorts of things like that. Because there's a whole package to put together. And with that, you can actually provide really, really good care towards the end of life for people with dementia. And you can support the carer so that they feel supported and feel more able to manage. And that we call increasing resilience. So you've got lots and lots of things that you put together. Continence, you know, in the Hope for Home study, which is the study we did of detailed interviews on 14 patients, the most important thing in terms of coping were incontinence pads. Intriguingly, the most important thing, well, I should say continence care actually, the most important medication in terms of coping were antipsychotics, rated by the carers, because they were the things that enabled them to manage their loved ones at home, and which were effectively reducing and relieving that distress. Without this service, we'd be lost. Mum would be in a care home and Dad faded away by now. We had a better year than we had in a long time, and that was one of the feedback things. So enabling people to live well, a good integrated care plan, building resilience. We got some great feedback, that's really nice, and holistic care and holistic assessment with rapid access to advice. And there, in fact, is a picture of Grace before discharge from her care home, and then after discharge, given to me, and the husband's always asked me to show these things. Hospital admission in the last year in our service is 25%, not 80%, with big savings on care home and nursing home budgets. And we reckon we probably saved about £2.5 million over doing 100 people. So lots of benefits there. Avoidance of admissions, avoidance of hospital admissions, better access to diagnostic care, better domiciliary care, integrated support, someone to pull it all together, supporting the whole family, and really good carer satisfaction. And also I'm in error now, aren't I? A euro sign at the bottom, saving money. How do we build resilience? Somebody who's a single source of support and advice, competent in managing distress. One of the interesting things is people often think, and many of my colleagues have thought, that as time goes on, people's distress settles down and they become physically unable, and there's a transition from being someone who's got agitation, wandering, and things like that to someone who becomes quiet and placid. Actually, that isn't true. We've carried on having to manage the distress and the psychiatric and psychological distress throughout the whole of the illness. It doesn't go away. It changes a bit, but it doesn't go away. The physical management of advanced disability, getting the right social service support, getting the right physical aids, beds, hoists, and all that, bringing in the appropriate GP and district nurse input, OT access, carer support and assessment, occasionally respite, but only rarely so, because actually respite is too disruptive to the health of the patient. And then being responsible, being willing, and bringing this wonderful thing called hope, actually. Here's an example. Mrs. A lady with advanced dementia, epilepsy, myoclonic jerks, trigeminal neuralgia, huge restlessness and agitation, not really saying a word, certainly to me, and a family who wanted to keep her at home but felt that would be impossible. Now, just to add, a quick aside, we've talked a lot today, and we keep thinking, and I think we keep falling back a bit into default mode of thinking, well, if they lack capacity, they can't really tell us if they're distressed, or they can't really communicate. Actually, they can, and in my dementia intensive care unit, which I was running until a year ago, with people with the most advanced dementia, you carry on talking to the patient, being with the patient, listening to the patient, picking up those signs, and so on and so forth. Ongoing regular support, less frequent once things are stable, but knowing, and the family knowing, that if there's a problem, they will ring you and you'll be there that day, or possibly that morning. Able to stay at home as a result, doing really well. Mrs. A then had a crisis, an episode of choking. The ambulance was called, but the family didn't want her to go to hospital. The GP was called. She got there seven hours later. We gave some telephone support and visited that evening, and we did avoid that hospital admission, because it built confidence in the family and because it enables that bit of better care. So we started with a model which worked with a few patients and a few families, but it actually works with other dedicated carers. So we now got a team, and we've developed a team, and in fact we now actually have a funded team, which is absolutely brilliant, supporting people at home with complex and advanced dementia. And health service staff like that, but the families like it very much, and very positive feedback from carers. So there we are. We've already just seen this graph in another form, but that's the transition. Early on in memory clinics, where I now work, you're at the blue end, where I work hard to actually make sure we talk a little bit about palliative care, starting to introduce the thoughts about palliative care. But we do diagnosis there, and as the dementia progresses, there is a transition towards a more palliative approach. But the problem with dementia is that, as we saw earlier on a slide in a previous talk, and I don't think I've got that slide in this one, the progression of dementia is not like cancer. It doesn't have this sudden deterioration and transition at a much clearer point to palliative from curative. Dementia deteriorates unpredictably, and what we know about the prognosis of dementia is that we don't know what it is in any particular individual. We cannot predict individuals. And in fact, with the recent NICE study on end-of-life care, actually the database, the evidence base shows really very clearly, firstly, that data is derived from cancer care, secondly, that we don't know what the prognosis is, particularly in frail elderly and people with dementia and neurological conditions. It's not predictable, but we know it's unpredictable. So actually, there is a transition to palliative care. You gradually think more about it. And I think, as Karen was saying this morning, talking about it at the very beginning is very complicated because actually people are just getting into the concept of someone, a loved one, having dementia. Core principles: good dementia care, accompaniment. And that's really important. It's in the UK dementia strategy. There should be someone to accompany a family with dementia. Actually, memory services are so pushed in terms of volume that we're actually discharging people once we've diagnosed and saying, come back whenever there's a problem. And I'm just not sure that's enough, actually. But a care-coordinated approach, learning and understanding the principles of palliative care. With antipsychotics and other medicines, which are sometimes thought of as chemical restraint, but in fact at other times are specific treatment for psychosis, and if they are the effective treatment of distress, are surely not only okay, but ethically required. Thinking through all the causes of distress, thinking through the other causes. Every time you have someone who's distressed, thinking about that differential diagnosis, is it pain? Is it depression? Is it poor care? Is it hunger? Is it thirst? Is it boredom? Is it just watching too much Blockbuster on Wednesday on every afternoon of the week? Because there is that tendency to feel that people spend a long time sitting in front of the television, which one does worry about. And the transition from curative medicines to that more palliative approach, and needing some real literacy in advanced care needs. And also special sets of skills around swallowing, nutrition, and also analgesia. It's a very important issue. Although, in our dementia intensive care unit, we did only find that about a third of people really benefited from analgesia. In fact, it's not the universal thing which is solving the distress of dementia. It's solving some of the distress, and it's wrong to miss it, but on the other hand, it's not the whole answer. And that's gradually grown, and we've now got some funded services. And what I thought I'd do is, rather than talk too much, which I probably have, show you a quick video and then just finish with 2 or 3 quick comments. Actually, I wonder if it's a... Hang on. Oh, crumbs, what have I done? We won an Innovation Award from the NHS for our work with the Greenwich Advanced Dementia Service, and here's a quick video of it.
7th of January 2011, Mum was diagnosed with mid-stage Alzheimer's disease and vascular dementia. There was never a question of not keeping Mum at home, whether or not I could manage to care for her as well as she needed to be cared for was something that we were going to decide in months to come.
With dementia, especially if you're looked after at home, the normal thing is that there's nobody there to support other than a GP who is not expert in these matters. Patients' relatives wanted us to let them take their loved ones home.
GADS initially came on board in January this year. They removed a great deal of the isolation that I felt. They actioned things. They didn't just talk, they did, which is what I needed. They didn't preach, they weren't judgmental, they listened.
We coordinate and accompany people with advanced dementia living at home through until they die. We look at the physical needs, the mental needs, the carer needs, the equipment needs, and all those things. Bringing expertise on all that together makes care of advanced dementia at home possible when it simply isn't possible otherwise. If you count the cost of care homes which patients have not gone into because of being looked after at home, and if you count the cost of avoided hospital admissions, on a caseload of 20 patients, we're saving probably £250,000 a year. And over the lifetime of our project, we think we've probably saved the local NHS about £2.5 million.
If Mum was in a hospice or a nursing home, I don't know how I would have dealt with that. I don't know if I'd been able to function properly at work, at home, anywhere.
Living well at home with dementia till you die, living with family, living with friends, and actually living in a supportive place which is not institutional. And that's a tremendous opportunity for lots and lots of people.
GADS validated Mum's importance for me. They reached out for her.
And if home is not the right place, care homes can and should operate to a high standard, delivering really, really good care. If I can, just a couple of quick comments. Dame Cicely Saunders set out the concept of total pain. Total pain, strongly recognised in palliative care, is about physical pain, mental pain and existential pain. It's putting the whole thing together. The distress of dementia, the mental pain of dementia, is just as important as the physical pain. And if I was to tread on your foot and injure it, you wouldn't mind a bit if you didn't know I was doing it and you had no physical pain because you had, say, a numb leg. But the moment you see it happening, you'll be hopping mad with me. So mental pain is really important. Actually, we need to treat the mental pain in dementia as well. And dementia comes with this earlier loss of capacity and understanding, and also quite a lot of those neuropsychiatric complications, depression, psychosis, which we need to be dealing with, and which does need the expertise and skills, I think, of dementia services. So cognitive symptoms persist throughout dementia, and as a result of that, there's ongoing treatment. Really important to try and get that right, but palliative care services need dementia services, just as dementia services need palliative care services to make it go together. And one of the questions is how that happens. We haven't solved that properly yet in Britain, and it will be a while you solve that here. But it is important to try and get the two together so that people can get both palliative expertise and ongoing dementia support. Finally, we've talked a lot about personhood and agency, and actually, I hope you can see there that there's one person described, but more people than that, who actually continue to give right through to the moment of death. And actually, even in an advanced dementia, when someone cannot communicate, you see beautiful things. And I remember one daughter whose mother had been very hard on her for a long time. She looked after her at home, and the day before she died, she'd done something, sorting her out in bed, moving her pillow, and she just looked up and said, "Thank you." First word she said in ages, but somehow that transformed that daughter's experience of losing her mother. And somehow, it is extraordinary, but I have so often seen those people with the most advanced dementia carrying on giving to their family right through to the very end, which is a lovely thing and a great privilege to see. There I shall stop, and we shall take questions. You turned my red light off, which was very kind of you.
I felt bad. felt bad giving you a red light when it was such an interesting presentation. So, yeah, Mary.
Thanks very much. That was a great presentation. I suppose I have a comment and a question. The comment to you relates to how important is it for people with dementia to be able to access specialist services in order for them to die at home. And when I talk about specialist services, not just specialist palliative care, it's old age psychiatry, it's access to gerontology in the community. When we did our study, we found that that wasn't available for the people with advanced dementia dying at home. The other is a query about how frequently have you seen people who are living in nursing homes go back home maybe in the last 6 months of their life?
Well, when I worked in the community, which I don't do now, we had a whole string of people who families would say, we want this person back at home. And actually, with the right support, it can be done. Although you have interesting conversations, including with different agencies like social services, about is it safe, might they die, and things like that. And you come back to this, well, that's what they're doing, sort of thing. So it's the same set of questions that you will be having in palliative care about is it safe to send someone who's dying home in case they die, kind of thing. And you know, what if harm comes? They're right and proper questions to ask, and we should be asking them. But on the other hand, surely at the time when you are dying is the time when you can take some particular risks, actually. There must be some legitimacy to that. So I think it's definitely doable. In fact, what we've done is we've then also found people in the acute hospital who we said, look, actually, we think we could look after you at home. And the point is that engagement from either palliative care or an advanced dementia service, whatever you want to have, actually is the enabler, which gives people the confidence. And then you have those conversations about illness planning, about what you will do when there's a deterioration. And you have those conversations about what it's like to not send someone to hospital and whether the risk of doing that is greater or less. Because actually, you know, hospitals are fairly lethal places. So you have a whole set of conversations. Then later on, you have a set of conversations with someone who's never been with someone who's going to die about what it's like to die. But you folks know that because you're doing palliative care all the time. So you know you're supporting it. And it's the same, so in other words, it's the same set of things. But actually, what a lot of our carers would say is that it couldn't have been done without that specific support. There's a tiny story in here. I did have a lovely lady with a lovely family who had dementia and was actually quite challenged and quite distressed by it with all lots of things. And then she got a squamous cell carcinoma on her leg. And once she was diagnosed with cancer, I sort of looked at it and said, well, let's not do a radical operation on that, because in fact I don't think her life expectancy is such. But we'll do a biopsy so we know what it is. So we did a little biopsy, sent it off, and then she got diagnosed with squamous cell carcinoma. And then suddenly Macmillan services turned up, and we had lots and lots of services. And then she carried on, but she didn't die of this squamous cell carcinoma, so they took it away again. And then after a while I went and did a visit, and I was worrying. I drove there and thought, well, what am I going to do about this squamous cell carcinoma? Because she hasn't died as quickly as I thought she would. You do not know what the prognosis is in any individual. Prediction is difficult. And I went along and I sort of had a chat, and things were okay. And I looked down at the leg and thought something funny about this leg, because there's no bandage on it. So I said to her son, well, what about the leg? He said, she pulled it off. And it had gone. She'd actually done her own removal of her own carcinoma, which is extraordinary. But, you know, the point is there is at the moment a different approach to the way we respond to cancer compared to the way we respond to dementia. And I don't think that's quite okay. I think that's actually not okay. We should be giving really good support to people with dementia as well. Although we recognise that it might need some different frameworks, because actually the capacity of palliative care to look after all those people, especially when we're not quite sure how long they're going to be on the caseload, isn't there, and it needs to be done in a different collaborative way, probably with primary care, district nurse services and dementia services and palliative care supporting. So there is a different framework, I think, to do it, but it cannot be argued that it should not be done.
Up at the front. It'd be great as well if people could make suggestions around research priorities as well. coming out of the presentation.
Oh, sorry, mine's not going to be about research. Sorry, just to introduce myself, I'm Judy Williams, and I'm here today with the Alzheimer's Society of Ireland because I'm on the committee of the Dementia Carers Campaign Network. I'm also on the Dementia Friendly Communities Initiative, and I'm a committee member of the Alzheimer Cafe in Donnybrook in Dublin. But actually, I'm a former carer. I looked after my father who had Parkinson's and 3 forms of dementia. And I just wanted to say, first of all, that was a lovely, very moving film there that you showed, video. I suppose I want to say a couple of things. One is going right back to this morning about the advanced care planning, and to say that luckily my dad had a living will, and I found that hugely important in understanding his desire to stay at home. I lodged it with our GP, and when he was taken into hospital with pneumonia very close to the end of his life, I lodged it with the hospital. And then I was able to use that to allow me to bring him home to die at home with the help of palliative services from the hospice, the daffodil nurses, etc. So there was a question earlier on about does advanced care planning have positive outcomes? I think it really does. That would be my point of view on that. And my second thing, just on something that was said in this presentation, was about the GP and district nurse support. And I would say that's hugely important for me anyway, in keeping dad at home. I don't have family here. I moved from England to look after my dad, so all my siblings are abroad. And I certainly couldn't have done it without the support of GP and public health nurse, because we don't have a system like your Oxleas system. So I guess that's really just what I wanted to say.
I mean, it's true to say that what I've found is that it needs somebody to do it.
Yeah.
And if somebody might even be anybody, it still needs somebody to do it, but often enough nobody does it. It's the old rhyme. But actually that somebody does need then to have the access, when it is required, to the specialist dementia support and also the specialist palliative support. So it's about making sure that there's someone there to do it. Because actually you don't want 6 or 7 agencies all doing it, every single one. You want someone to pull it all together. The other interesting thing about, I mean, what I would do is I would echo what was said this morning about the concern about the term end-of-life care. I think palliative care is better because certainly in my experience and in the newspapers in England and elsewhere, when you talk about end-of-life care, people think that's all about dying. And what we're doing today is talking about living as well as we can while we die, accepting that we are and accepting that is the outcome. So palliative care has, or possibly care towards the end of life, but palliative care has the opportunity to transform that. And I thought that the comments this morning about focusing on palliative care as a term were actually very sensible, really. The other thing is, if advanced care planning is effective, then actually the question is, what are the benefits? But if any treatment is effective, we should also ask what are the risks. And there is a problem in there, which is that at least some of the time people become distressed early on by ACP discussions. I know my father-in-law was rung up by the practice nurse asking if he wanted to be resuscitated at the age of 92, and he found that a bit of a left, out of the blue conversation, but it was in something we call a sequin in the UK, which means that the practice had to do it because they wouldn't get paid if they didn't, kind of thing. So, there's complexities to it, and it's about deciding how and when you do that. But I think we should be aware that advanced care planning and advanced refusals actually have benefits and side effects. And for example, with an advanced refusal, if you say, if I have dementia, I want no active treatments, we still have to decide what will we do if this person with an advanced dementia at the time when they've lost capacity gets a urine infection. Well, it's the best symptomatic treatment. So we have to work around that and work out how those things get interpreted. So we do need to be aware of the challenges. But on the other hand, people often find them supporting. I have found 1 or 2 people who really good advanced care planning just didn't support them. They couldn't feel reassured. And that's actually quite a difficult challenge, actually. There's a question about understanding their limitations as well, especially at a time when the benefits are poorly documented. Any more questions? Any more thoughts on that? I mean, there's a whole discussion in there, possibly for later.
First of all, thank you very much. Brian Lauder from St. James Hospital in Dublin again. Thank you very much for that. I think that was inspiring for me as an old age psychiatrist, seeing what you can do it's just amazing to me. And
There's nothing like a professional film company to make it.
No. I actually wasn't referring to the film. I was referring to what you were doing, actually, because I think it was an incredible service, and it just shows you what you can do, and it's just really fantastic. I think in terms of maybe the research question is for Ireland is how, in terms of the health service provision and health service model, how do we do something like this, and how do we evaluate it, its cost effectiveness and so on and so forth, and I think that would be a really good question, because it seems to me that you can't do this on your own. A geriatrician can't do it, a psychiatrist can't do it, palliative care people, it has to be done, and nursing and district, it has to be, it's a joint, again, everybody has to do this together, I think, as I understand it. You have to work together in the community to do this. The second point I'd like to make is, again, you go back, you mentioned this morning about distress, and you mentioned again about mental distress, which I think, again, speaks to the behavioural or the psychological symptoms of people. And I wanted to ask you a question. I mean, it seemed the pictures you showed and the movie you showed was of people who are relatively immobile, as they were, perhaps they weren't, but that's what you showed. And I think one of the difficulties, as you know, with behavioural and psychological symptoms of people with dementia, with the moderate to severe stage in the community, in the hospital and in nursing homes, is when they are mobile, and it is very difficult. They're very distressed. It's difficult, but it's also difficult to manage people in that type of environment. But even at home, it can be difficult without risk to manage. And I just wonder, is there a particular stage or kind of presentation that is more manageable, as you described it here in your program, or not? Or can you also address the patient who is very ambulatory and shows a lot of mental distress?
Okay, so that's almost 3 questions, but that was very good. Now, the first is, in Britain, there's a big fashion for something called integrated care, and that's seen as putting together all the disciplines, primary care, geriatric medicine, a bit of old age psychiatry and district nursing, and everything put together to provide the alternative and care in the community, so that we can pick up people who may get admitted and avoid hospital admissions and provide an alternative pathway. And I do think there is a research question in here, which is in the Irish context, what would be the service structure which enables that kind of thing to happen? How do you pull that together? What do you pull in to make an alternative pathway for people with dementia, so that there is an opportunity of care at home for those who can do it? And actually, by the way, that almost always requires a carer at home 24 hours a day. It's not for the part-time. And how then do we provide that kind of care and that kind of solving problems in care homes, which is the place where the majority of people will still be? The second is the challenging behaviour question. And if I or anyone in this room goes up to anyone else in this room and stands them up and starts undressing them and putting them on a commode in this room, we hope there will be some challenging behaviour. Challenging behaviour is an appropriate response to poor care. But in dementia services, we call challenging behaviour the problem, although in fact it's, of course, the problem for us and not the problem for the patient. So actually that's why I much prefer the term distress, because that's patient-centred. And actually, if the cause of the distress is me going along and pulling someone else's pants down completely inappropriately, then actually the solution to that challenging behaviour is probably for me to be fired. It's as simple as that. So, I do think that challenging behaviour, although it's been measured and is measurable, has been a corruption in old age psychiatry, because it's been a measurement of the problem the staff have rather than a measurement of the problem the patient has. And that's why a scale in distress would be very, very good. It is absolutely true that when people are no longer mobile, they do stop wandering. And it's kind of a cure for wandering. What I have seen, and I guess you will have seen it too, is that in the people who were more psychotic earlier in dementia, as they progress, they may lose the ability to put it into words, but they continue to be agitated. And I've seen those people stopped in terms of antipsychotics, get more agitated, and then settle down again when they go back on them. So I think what happens is, often enough, the problem persists through the illness, but it changes in its expression. So you do get, in more frail, more bedbound people, a change in expression to something which in some ways is more manageable. But in another way, it occurred to us that it seemed to be just as important to treat it. That it wasn't actually going away, it was merely changing. you know, what we know about dementia, it's a progressive condition, therefore needs change throughout the whole continuum of the illness. So I think it's just about addressing needs at the time, and as a result of that, the solution, today's solution, is never really tomorrow's solution. It's an ongoing progress through an illness with adjustment, which is another reason why that accompaniment is actually quite important, because if it's going to change, you carry on needing some expert advice as to how to change it. You shouldn't get dementia and be put in a hospital bed the next day. There's got to be some other process of good quality care, living well with dementia, and adequate and appropriate support through the progress of a progressive illness. Any other?
Any other?